It is the buyer who did the first spinal anesthesia. Anybody answer it as Morton? I know. There is a ether dome in Harvard Medical School. Some of you, after finishing your MD, I know what you will do. That time you will write USMLE. You know there is a trend like that. Why USMLE MD के बाद लिखते लोग? Two reasons. Either they did not get married till then, so that USMLE के वजह से शादी होगा अमेरिका की NRI boy or girl से. Second, at least अमेरिका में फेल हो गए तो इंडिया में काम करने के लिए एक MD डिग्री रहेगा ना. So that is another reason. So doctor, when some of you go to do fellowship, okay, MD general medicine, DM nephrology के बाद you will go to Harvard for fellowship, no? That time you go and see the ether dome. Huh? It is the Morton who is a dentist. Actually, he is not a medical guy. There was no NEETPG for him. So he had time to discover nitrous oxide, first inhalational anesthetic. And unfortunately, when he first time tried to demonstrate, he had a lot of difficulty. Everybody was skeptic. He will definitely go wrong is their assumption. How can pain will not be there? There is a book called Goodman-Gilman, Pharmacology. In that they write a beautiful story of how it happened to Morton. That's a story that you can love to read if you are a good reader, or any Google blog. Now, that is nitrous oxide, the first public demonstration of the property of anesthesia was done by a dentist, Morton. But Bayer is the guy who did, first time he poked needle and did spinal anesthesia. And Vallius Cordus prepared the ether, and Humphrey Davy discovered that it can lead to laughing in a pathetic life. Now, simple bone cyst, non-lytic lesion, how do you differentiate? There is a classical sign called fallen fragment sign which will differentiate between the two, which is very important, which is pathognomonic of simple bone cyst. I could not get a radiograph of a simple bone cyst ke andar, it looks like a fallen fragment, which is characteristic. Now coming to chest radiograph, how much pleural fluid should be there in the case of lateral, how much in the AP or PA view? Typically doctor, 200 ml if it is PA view, lateral view may 75 ml for the costodiaphragmatic blunting to be appreciated. Okay doc, should be an answer. Mucosal, lumpy, bumpy neuromas, where do we see? Yes? Meant to be? I think meant to is not sufficient. B, yeah, that's right. So meant to be lumpy, bumpy neuromas. Men's syndromes is a favorite issue for the examiner. Asbestosis, upper lobe or lower lobe? Typically asbestosis, fibrosing alveolitis, drug reactions, they are all lower lobe. Everything else is upper lobe. Downs can lead to abortions. Despite the high frequency of abortuses, still downs will be born. That's unfortunate story about down. Then you can use nuchal translucency which is increased. You can also use triple screen for down. Between the two, which is better? Triple screen can be biased if there are twin pregnancies, but nuchal translucency won't fail you to diagnose the Down syndrome. It is much more consistent. Alcohol, fetal alcohol syndrome, classically you have microcephaly, everything. Then respiratory distress syndrome, if the PG level is good, then the RDS is less likely, least likely only, no, least chance. Then hyperemesis gravidarum, for diagnosing it is the ketonuria, which is a very important indicator. In fetal hydrops, placenta, how it is, big size, edematous placenta is what you come across. Forceps, vacuum, what are the differences? Forceps can injure the cornea, but vacuum is more vulnerable to lead to cephalohematoma, intracranial hemorrhage, jaundice because of that blood of cephalohematoma dissolving. All these are more common with the vacuum, but with forceps, corneal abrasions are more common. Now, 24-year-old, 40 weeks of gestation, transverse lie. There is no way that you can deliver transverse lie vaginally unless you do exocephalic version is the way. Now, you have just delivered an infant weighing 39 weeks, and after that uterus is still large, that means there is a twin pregnancy. What is the only indication, obstetrical indication, the modern practice of the obstetrics for the internal podalic version? The second in the twins in an abnormal eye becomes the indication. Okay, doc, give me an answer. Which is the GP1 analog? GLP1 analog, which decrease the glucagon, increase the insulin, which we use in the management of diabetes. Very good. There comes the answer from all our online users. Sunain correctly answered it as exenatide is what need to be remembered. So, doctor, diabetic drugs we doing mistake is unpardonable. We use pramlintide, which is basically a mimetic which decreases the glucagon used in type 2. We use acaribose miglitol, which are alpha glucosidase inhibitors. We have GLP1 analog like exenatide is what need to be remembered. Now, 24-year-old, primary gravid at term had been in labor for 16 hours and had been dilated to 9 centimeters for 3 hours. How do you want to manage? What is your diagnosis? Dilated 9 centimeters for 3 hours makes it a secondary arrest of labor. Secondary arrest of labor. So, how do you manage? Since there are late decelerations, that means fetus is getting compromised. So, you need to do an emergency cesarean and then expedite the delivery for the management of the secondary arrest of the labor with a deteriorating fetus is what need to be remembered. Alright, doc. 29-year-old G2P1 active labor for 41 weeks, at 41 weeks with cervix position being given, and epidural was given for pain control. Oxytocin had been given for contracting uterus, and the fetal heart rate has been found to be, has been in the in 70s for the last 3 minutes. What you don't want to do, a prolonged fetal heart rate deceleration with the isolated decelerations longer than 2 minutes but lesser than 10 minutes. What do you want to do? Since you have given epidural, it can lead to the development of maternal hypotension and a decreased placental perfusion. That's the reason you need to check the maternal BP, and if the maternal BP is abnormally low, then that becomes an indication for giving ephedrine, sympathomimetic, to correct the hypotension in the mother, because she had already been given epidural. Then since she was receiving pitocin, oxytocin infusion, it can lead to hyperstimulation of the uterus and may be responsible for fetal hypoxia. Stop the drip. And put the patient in left lateral position, which will improve the perfusion to the fetus. Only if the fetal heart rate deceleration is persisting, then it becomes an indication for doing an emergency cesarean, otherwise it is not, is the idea of this question. I think too long a question about the clinical management in obstetrics for a single liner exam is, but still. 21-year-old, difficulty in voiding the placenta, postpartum, what are the causes? If you have given oxytocin after delivery, vulvar, hematoma, urethral trauma, any of them can prevent the shedding out of the placenta. Now coming to the postpartum depression, 1/10 of the women develop postpartum depression, and young multiparous patients, there are some safety factors, unsafe factors, and whether earlier history of depression has a relation with postpartum depression, all this is a big literature. I leave to you for you to review. Granular cell tumor produces a lot of estrogen, and hence it's a risk factor for endometrial carcinoma. Okay, doc, shoot me an answer. Our number of viewers have fallen down from 45 to 34 with food being the, lunch being the main priority. All efforts are ultimately to have a sumptuous lunch. I know, already it is 3 o'clock. Okay, doc. Weight gain, edema, hepatotoxicity, heart failure. They are all the problems with which diabetic drug? Who will give me the correct answer? Excellent. Kurnool students have not yet gone for lunch. Pioglitazones. Okay, doc. Glitazones, you need to remember, the main side effect is it can lead to development of heart failure. The incidence of heart failure and coronary strokes have increased in the people who had been receiving glitazones, is what need to be remembered. Suckling will increase the prolactin, as all of you know. 64-year-old with hysterectomy undergoes hysterectomy, then what complication can develop within 2 weeks? Post hysterectomy, there is a great risk of developing stress urinary incontinence, is what need to be remembered, unless at the time of hysterectomy the uterovesical angle is respected and maintained. If it is missed, then that can lead to development of post-operative stress incontinence. Marshall-Marchetti-Kranz operation. What do you do in this? The name is bewildering, but procedure is simple. You attach the perierythral tissue to the symphysis pubis. Since you are stitching it to the symphysis pubis, it can lead to pubic osteitis, which can be painful condition post-operatively, is what need to be remembered. Incontinence, prolapse is one topic, doctor. Quagmire in gynae preparation. What is left out, what is the advantage, what is the Sirotkar, what is Marshall, Marchetti, Kranz, everything.